Good morning, friends. Welcome back to my YouTube channel, Medical Class by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please click the bell icon. You will also the playlist recorder. You can make use of it for the purpose of continuous study. Thank you very much, my dear friends. We were discussing about muscular dystrophy. We are discussing muscular dystrophy through a case study. In the last class, in the present case, we have discussed about the Gover sign and why Gover sign will be there, why it will be positive, and we have discussed all the details of that. The problem with the proximal group of muscles, which are also considered as anti-gravity muscles, so they fail to perform, then the patient has to use the other muscles, probably the distal muscles of the upper limb, for the purpose of getting up from the sitting position, and that leads to the existence of a Gover sign. But most commonly, the proximal group of the muscles related to the hip get affected, and as a result, the gluteus maximus, gluteus minimus, intermedius, etc., gluteus group of muscles, adductor group of the muscles, so they are not able to stabilize the hip, and as a result, there will be the tilting of the hip when the patient is walking or child is walking, and that leads to the waddling gait. There will be tilting of the pelvic forwards and sidewards associated with the to some amount, so there will be a problem in the lumbar region, so leading to the forward bending of the lumbar region. So that may be a cause for the waddling gait. Now, based on the history, in this particular case, based on the history, it is quite clear that it is a muscle disease, isn't it? So in this particular case, it is a muscle disease which is started in the lower limb and gradually increasing chronic disease. This is the classical nature of the muscular dystrophy, chronic progressive disease. So this here it is started in the lower limb. Okay. So when I say muscle disease, dystrophy is one of the muscle disease, no doubt. But there may be other problems related to the muscle disease also which needs to be differentiated. For example, apart from muscular dystrophy, a muscle disease may be in the form of myopathy. Myopathy means the functional involvement of the muscle. Another problem related to the muscle is myositis. Myositis means inflammation of the muscle fibers. Or it could be a muscle atrophy, as it is in case of spinal muscular atrophy. Or it may be a muscle hypertrophy sometime. Or it may be a muscle dystrophy. Okay, so now if I am talking about muscle atrophy, muscle hypertrophy, and muscle dystrophy, all the three are considered under the category of structural abnormality of the muscle. Whereas myositis is inflammation of the muscle. Myopathy is nothing but it is a functional involvement of the muscle, not structural, functional involvement of the muscle. The muscle function is not proper. Structure wise it is normal. So now when I consider muscular dystrophy, so it comes under the structural abnormality of the muscle. Now I have to differentiate this particular structural abnormality, that is dystrophy, from the other types of the muscular structural problems like atrophy and hypertrophy, number one. Then I have to differentiate it also from the myositis. Then I have to also differentiate it from the myopathies. Okay, so we will take one by one. Let us differentiate myopathy and dystrophy. Of course, myopathy is a functional problem of the muscle, whereas dystrophy is a structural problem of the muscle. Okay, how to differentiate? Now, myopathy could be congenital. Similarly, dystrophy is also congenital, no doubt. Okay, but only difference is in case of myopathy, congenital myopathy like mitochondrial myopathy or congenital lemon myopathy, etc. These are the example. Okay, so in case of the myopathies, usually the problem will be static. Okay, the functional problems of the muscle, myopathies like congenital myopathy, mitochondrial myopathies, etc., where the problem is not chronically progressive. It is chronic, yes, definitely, but static, chronic static problem. Or myopathies may be very slowly progressive, not so fast, so rapid as we see in case of dystrophies. Okay, so they are either slowly progressive or not at all progressive or static. So this is one of the major difference how we have to differentiate from the congenital myopathy for any type of myopathies from the dystrophies. Muscular myopathies and muscular dystrophies, this is one of the method of differentiation. Myopathies are slowly progressive or static, whereas chronically progressive conditions are muscular dystrophies. We know dystrophy is also congenital, isn't it? But the progression is very fast compared to the myopathy. Okay, so patient will be confined to the wheelchair very fastly. Within 3 or 4 years, patient will be confined to the wheelchair. But it is not the case with congenital myopathies. Okay, now this is one important thing. Now, in the history, so we know that, of course, another important thing that we have to identify is myositis. We have to differentiate myositis. Myositis is inflammatory condition, so definitely the child will be having fever and swelling and all the symptoms will be there. Okay, so that can be very easily differentiated. But the problem comes to the myopathies and the muscular dystrophies. Now, based on the history now, in the history there is involvement of the trunk muscles also, isn't it? They told the patient is not able to change the side, etc. करवट बदल नहीं सकता है. So he has some problem on turning in the bed. Okay, so there is no head lag, but luckily there is no head lag. If there is a head lag, it suggests that the muscular involvement is more progressive, and even the extensions of the neck is also get affected. Okay, so we have extension of the neck, like trapezius is there, paravertebral muscles are there. But like in this patient, these muscles are not affected because head lag is not there. Suppose if the head lag is there, it suggests that extension muscles on neck is also get affected. But of course, the problem is there with the trunk muscles. Okay, trunk muscles have slowly started involvement. Now, these muscles are involved by the head lag. Okay, head lag and involvement of these muscles. Okay, extension of the muscles of the neck. So it will be seen in case of muscular dystrophy, but it will be also seen in case of some other condition, for example, myotonic dystrophy. That will discuss later. Okay, there is no condition called myotonic dystrophy, which is weakly into that of muscular dystrophy. It is not muscular dystrophy. Okay, so myotonic dystrophy. Then also it happens in snake bites. Usually, what you say, the head lag will be there, no? Head lag will be also seen in case of snake bite also, because snake bite is a neurotoxic poison. Head lag can also seen in case of Levy syndrome. Head lag can also in case of myasthenia gravis. Okay, and head lag can also in spinal muscular atrophies, like amyotrophic spinal muscular atrophies. So in that condition also head lag will be seen. So head lag can be seen in case of muscular dystrophy if the extension muscles of the neck are get affected. But apart from that, there are some other conditions where commonly head lag will be seen, as I mentioned here. Now, in this case, the wasting is also seen in some of the muscles, especially if you look into the case, wasting is in case of biceps and gluteal muscles. Okay, the history suggests of them. So now this suggests of LMM lesion with the axonopathy or long-standing myopathy. Now, biceps undergoing atrophy and as well as gluteal muscles also undergoing atrophy. Of course, they are the proximal muscles, anti-gravity muscles. Definitely, um, their bulk may decrease. Of course, dystrophy is kind of the abnormal collection of the abnormal substance in the inside the muscle tissue. So there may not be exactly a atrophy like finding on outlook. Okay, so therefore we call it as a pseudo atrophy. But actually it is not hypertrophy, but it is pseudo hypertrophy because of collection of the abnormal lipid materials or abnormal materials inside the muscle fibers. But in this case, if you see, in this case, in contrary to that, the history suggests that there is some, what you say, loss of muscle fat or what you can say wasting in the biceps and gluteal muscles. So now we have to think in other way also. So because we should not have a preoccupied idea in our mind that this is a case of muscular dystrophy, we should explore all the other possibilities. Okay. So although the most of the symptoms are suggest of muscular dystrophy, but why this atrophy is in biceps and gluteal? That also has to be evaluated. So it because biceps and gluteal atrophy is commonly in some of the lower motor neuron lesion. It's a lower motor problem, isn't it? Lower motor neuron lesion. So how to differentiate it? Whenever wasting is seen, uh, it's not simply the wasting which is important or atrophy which is important. We have to ask for the fasciculations. Okay, suppose if the wasting is there along with the fasciculation, so it suggests the denervation atrophy. Okay, we will discuss in some other class. It's called as denervation atrophy, which is very commonly seen in case of motor neuron disorders or what you say the anterior horn cell disorders, etc. Fasciculation is very important. Atrophy with fasciculation, it's an element lesion. Other than this, there may be such type of biceps and gluteal atrophy can be also seen in opioid poisoning. Okay, now what actually happens in case of opioid poisoning, thyrotoxicosis, atropine, in that condition also there will be fasciculation. Atrophy may be there, may not be there, there's a different issue. Most of the medicines are there. But simple fasciculation is also seen in these three conditions also. Opioid poisoning, thyrotoxicosis, and atropine. So again we have to be very clear. Okay. So in case of muscular atrophy, although atrophy is seen, okay, there will not be any fasciculation. But if there is atrophy of the biceps or gluteal muscle, that is element lesion like lesion associated with the fasciculation, definitely it is a lower motor neuron lesion. The problem is only fasciculation may be seen in some other conditions also. For example, opioid poisoning, thyrotoxicosis, atropine, etc. So we need to be very careful. So everybody knows how to elicit the fasciculation. Simply tap the muscle fibers, the fasciculation will appear, or apply a cold, then also the fasciculation happen, or just hyperventilate the baby or child. Okay, that also leads to fasciculation sometime, because when you go for hyperventilation, there will be alkalosis, and that leads to hypokalemia, and then there will be what you say the fasciculation occurs. Okay, so therefore, what is important? Suppose a patient which is, you have already confirmed that this is a case of muscular dystrophy. He has got atrophy of the some of the muscles, not all the muscles, some of the muscles. Now you will have a doubt that there is a element lesion. To confirm that, what is important is fasciculation. This is how the fasciculation always confirms the lesion. Whereas if there is no degeneration atrophy or there is no fasciculation, definitely some other problems. Okay. So that's all for today. In the next class, again, we will discuss one more important fact related to this particular case. So when we are dealing with the muscular dystrophy, because what is that point? There is no floppiness. Okay. So now here there is no floppiness, although it is an element lesion. So there is no sensory involvement also there. So there is no neuropathy. There is no pain. So there is no inflammatory disorders of the muscle, just myositis, etc. All these things are ruled out. So the small muscles of the lower limb are not involved. So there is no involvement of the small muscles of the lower limb. So there is also involvement of the facial muscle, diaphragmatic involvement maybe all, because these are all the muscles. Diaphragmatic involvement is also there, and maybe there sometime, but in this case there is no diaphragmatic involvement. No involvement of the autonomic nervous system. Okay, if the autonomic nervous systems are affected, you will have incontinence of the urine, involuntarily passing the urine, the next is sweating, then heart rate problems. So these things will occur. So if it is not there, that suggests that there is no autonomic nervous system involvement. There is also no swaying of the limbs. Okay, if the swaying is more, that suggests the cerebellar involvement. But in this case, there is no swaying. Okay. Of course, in muscular dystrophy, in the later stages, you may get a swaying-like appearance when he is walking. Okay, that's different. So there is no cola-colored urine again. Okay. So why I am explaining about cola-colored urine? Cola-colored urine is usually indicates the problem related to the kidney. Okay, if the urine is containing cola color, so the source of bleeding is from the kidney, glomerulus. Okay, so what is the importance of asking about the cola color urine in this particular case is there is a condition called myoglobinopathies. Okay, myoglobinopathies. We know that what you say, hemoglobin is also present in some of the muscle cells also. Okay, so now what happens is if the muscles are breaking, muscle fibers are breaking, and some of the hemoglobin containing cells are also get broken, that hemoglobin enter into the blood and it will become the excretion through the kidney, and that time it's a hemoglobin, so it may lead to a red color. but by the time it passes through the urethra, it is converted into collagen. So in a case of muscular dystrophy, we need to also ask about the color of the urine. The reason is this. Okay, because it's a problem related to muscle. So anything can occur. Okay, even myoglobinopathies can also occur. There is no history of rash in this case. What is the importance of rash in this case? If it is myositis, one of the most common type of muscle disease, that is myositis. Okay, muscle disease, as I told, it may be functional, structural, or inflammation. Inflammation causes myositis. Okay, one of the most common type of myositis is dermatomyositis. Dermatomyositis. It is an autosomal disorder. So as it is autosomal disorder, in dermatomyositis you will have the rash. Okay, rash will be there. So presence or absence of the rash is also important to rule out this myositis. Okay, so these are not the basic things related to this particular case, how we have to go forward. Okay, it's not merely with a preoccupied mind. Just by looking at the Gobar sign, you will have idea that yes, this is a dystrophy. Don't stop there. But you have to explore all the aspects related to the muscular dystrophy. The rest of the things that we will discuss in the next class. Thank you very much.